how do you start to talk about condom negotiation? How do you start about protecting yourself? How do you start to talk about some of these things when you're in a state of disarray?
Yeah. Too often, Black women are a mere afterthought in conversations around wellness, but not in this space. On this podcast, the dialogue is always centered around women like you. Welcome to the podcast, but more importantly, welcome to the tribe. Be well, sis. I am super excited to be speaking to Dr. Maisha Standifer. So I am super excited to talk, especially as we are discussing, the world is discussing, HIV and AIDS transmission. So before we even hop into the conversation, one of the things that I like to ask my guests when we start the conversation is, how are they doing PMS? So P is physically, M is mentally, S is spiritually, and you can go as deep or as shallow as you want to.
So physically, I'm doing okay. I normally do, after I drop off my son, my 30-minute walk, and I do, a little weights. I had this interview, so I had to prepare, and I had a few kind of emergency meetings prior to this meeting. So I'm doing okay. Yeah. Afterwards, I plan to go on my walk, or at least do my 5-minute yoga app session.
I love it.
Spiritually, I'm doing great. I have some activities that I am partaking in my church this weekend, so I'm excited, motivated, and mentally doing better. I didn't have my therapy session this month, but I plan to have that in the next 2 weeks. So my PMS is clicking in kind of from a scale of 1 to 10, 10 being the highest, about a 7.5 to an 8 today.
Okay. That is good. That's not
good.
bad.
Okay.
Yeah. So I appreciate you sharing.
Thanks for asking.
So I want to get into your work. So you have done over 15 years of research in the HIV and AIDS pandemic, specifically in the southern part of the United States. I would love to know what inspired you to go into this field.
I'll start a little bit in terms of having a family, of course, very situated and if not from the South. I'm originally born and raised in Ohio, but family from Alabama. So every summer we were shipped down 75 and 65 highways, and we were placed there for the summer. My sister and I would come back, talking the Southern twang, the Midwestern individuals. They were like, what are they talking? Where they been? But it was also, talking about growing up in those summers with grandparents, cousins, great-grandparents, and that familiarity of love and comfort, right? And security. So me coming back to the South, being educated in my undergraduate institution in Atlanta, and then continuing to focus on health equity and health disparities early on, and development, and that kind of molded the opportunities that I have today, and cultivate kind of my focus. And again, my career trajectory in terms of focusing on women's health, again, reproductive health and sexual health, and aligning it with all efforts related to health disparities research. So working at the Centers for Disease Control for a number of years allowed me to kind of, obtain a breadth of what's happening in respect of chronic illnesses, but also infectious disease. And early on, even undergrad and graduate school, I was able to work on projects, with researchers that focused on sexual health, whether it be in HIV, whether it be condom negotiation, whether it be self-esteem of Black women. And I wanted to really focus on educating, particularly Black women. That's who I was surrounded by, who I was raised by, loved by, and kind of guided to be like those individuals. And so I wanted to make sure that I was able to provide some culturally responsive feedback, comments. And when I introduced myself to community members, introduced myself as an academician once I graduated with my PhD, and again, talking and talking about messages and promotion of certain activities, and having no judgment. Again, making sure that people understood and knew what was needed in terms of to live a healthier life and to make healthy decisions. And so I think bringing that all into play now, me being the Director of Population Health at the Satcher Health Leadership Institute at Morehouse School of Medicine, allows me to bring all of that together and
Mm-hmm.
continue to move the needle forward in terms of advancing health equity.
Oh, I appreciate that. I love how you've been able to just make it
Yeah.
bring it full circle,
Hmm.
really.
Hmm.
Yep. You're educating the population that poured into you
Yes.
as you were developing and growing and developing. I love that. So I have the CDC fact sheet here, and the most recent data that they're publishing is from 2022.
Mm-hmm.
They're saying that there are 31,000 estimated new HIV infections in the US in 2022. Of those, 22% were among those who reported heterosexual contact, 67 were among gay, bisexual, or men who reported male to male contact. My question is, with the rising rates of infection of HIV in our population and in younger age groups, what are you seeing that is the cause of it? Because we talk about it. It's not like it's the 80s, early 90s where we were hush hush about the disease. Now I think there's more conversations being had, and there are contraceptive measures and things and barrier methods. So what do you think what are you seeing as the cause?
Over 40 years ago was the first kind of known diagnosis for
Mhm,
HIV and AIDS. We have to understand that some individuals, they weren't born,
mhm,
right?
mhm,
And but I can reflect back on having family members, having individuals that I knew that were diagnosed, but again, you didn't know what it was,
mhm,
and they weren't being, disclosing some
mhm,
of the day-to-day habits of who they were with, what was going on. And so you're thinking, okay, what's going on or what's
mhm,
happening? Individuals in my church
mhm,
that I, didn't know. I'm like, why are they sick? And then they're gone. They have pneumonia.
mhm,
Well, how does pneumonia into somebody, dying, immediately within 2 or 3 months? And then several years later, hearing, oh, it was HIV, it was AIDS.
mhm,
I didn't know Uncle Drew. I didn't know he was like that. I didn't know, so then you
mhm,
start to really inquire, oh, wow. And people say, oh yeah, lifestyle, but no one really talked about it in certain communities and family. And you're like, oh, well, gosh, is there something that could have been done? What was happening? And just a bit dismissive, right? And so again, leading back later on in life, when I'm talking about sexual transmitted diseases at that time, STIs now, infections, talking about the increasing rate in young people with syphilis and gonorrhea. What do
mhm,
we need to do, particularly from the agency of Black women and young women, saying, hey, if it does come a time where you're able to talk about sexual activity, relationships, then you should be able to place yourself in a power and decision where you feel esteemed to say, hey, no, we're going to partake in some activity. Let's use protection,
yeah,
right?
mhm,
Let me make sure I have the skill set and make sure that I impart upon the population that has knowledge on what they can provide
mhm,
for themselves and for the other
mhm,
individual that they're are connecting with. And so, again, going back 40 years ago, up full circle, it is not the same diagnosis. It was a death sentence 40 years ago.
yeah,
But now we have advocates, we have activists that we are working alongside with to
mhm,
help make sure that we get this message into the community, to young people,
yeah,
having more educational messaging and communications and portals and platforms. Social media is one. So understanding that now we have to make it very strategic in terms of how we identify those particular populations that are HIV possible.
mm,
If you are having sexual activity, you are HIV possible.
truly, yeah,
You are HIV possible. So,
yep,
what do we need to know? Whether you are same gender loving, whether
mhm,
you are trans,
mhm,
whether you are heterosexual.
mhm,
If you are having sexual activity, you are possible. So,
yeah,
what do we need to do to make sure individuals, and that's what we're doing to talk about addressing structural racism? That's a factor.
mhm,
Some of these communities, they're out of sight and out of mind. If they're not in my face, they're not in my family, they're not in my clinic, then I don't
mhm,
need to worry about them. But yes, we do. It is a circle of life.
Yeah.
in this world if you don't understand. And so that is one thing that we're doing at Morehouse School of Medicine in terms of addressing some of those social determinants of health and political determinants of health. And just to highlight, when I talk about social determinants of health, I'm talking about employment factors. If you don't have employment, then you're not readily available to go and get checkups, to go
Yeah.
get tested
Yeah. Yeah.
for STDs or STIs. We talk about structural racism that's embedded into every facet of our existence, right? We talk about the stigma related to HIV and AIDS. I'm not going to talk about it if you don't talk about it. Don't ask, don't tell. But let's have those robust conversations, even if you just bring it up at family reunions. Transportation is a factor. If you don't have transportation to get to a clinic, whether it be bus, whether it be a vehicle, or whether it be a train, or having a family member, connect you to clinical access and services. And then to also add to talking about the mental capacity, and you talk about PMS as you highlighted earlier. If you don't have the mental wherewithal to kind of think and accept yourself of a being that is worthy and deserving of being protected and being vibrant and living, then you really are going to have, some issues with kind of navigating, well, what's the right decision to make when I'm talking about my life, when I'm talking about my partner's life.
You mentioned, I wrote it down, condom negotiation.
Yeah.
So what is condom negotiation and how does it interrelate with this here?
Well, it's really interesting because, as you talk about, I remember working on condom negotiation research and tactics in the 90s. That was when it was really coming out and talking about, hey, let's be a little forthcoming, and particularly talking about with women, right? The onus would often be placed on men. And again, I think that was also around the time when the female condom, was being introduced. And so again, that was putting the onus on a woman, saying, hey, I need to protect myself just as much. So if I'm able to, have a female condom, or someone has it, or carry my own condoms, again, what does that mean? Again, we have to really be forthcoming when individuals, at that time, we were talking about introducing it to partners, because there were some, efforts where individuals saying, wow, if a woman is carrying condoms, that means she's very loose. And that means, I'm taking my health into my hands. You communicate the love for yourself to your significant other, or the person that you are about to partake in sexual activity with. You need to negotiate. I was involved in some qualitative research, getting to perceptions, and particularly in populations where the power is not often put on a woman.
Yeah.
And so many people were taken aback. Well, why would I do that? He's going to think I'm loose. He's going to think I got multiple partners, or he's going to, not pay for my rent, not pay for my bill, not pay for my baby's daycare. If I say something about, can you put on a condom? He's going to think that I'm thinking he's cheating, whether he is or not. Need to understand. So that was, again, talking about those negotiation skills, again, embedding upon women that you are worthy. Let's uplift your esteem and understand, hey, because we know that esteem is very highly correlated to whether you're able to say, no, that's okay. If you're not going to do it, we're not going to. But we also need to understand the dynamics of certain relationships aren't like that. And so that's where kind of negotiation comes into play.
Yeah. And this actually reminds me of, I listened to another podcast, maybe like a couple weeks ago, and she was saying how before she engages in sex with anybody, she asked for, hey, when's your most recent HIV test, and just your STD panel in general, STI panel in general, when was your most recent? And she was telling her friend about this, and her friend was just like, oh my gosh, like it was with judgment that they like were receiving what she was saying. So first of all, I think that is super important, because some people don't like the feeling of a condom, especially if you're going to be in a monogamous situation. So they don't want the barrier. So I think it's really important to talk about getting the test.
Yes.
But you also made a good point earlier about not everybody has access to those things.
And access in terms of, whether you have accessibility. I know we talk with college students, college age students, and use a wellness clinic, and
Mm-hmm.
some clinics provide condoms, free condoms. And then I also
Mm-hmm.
have, not everyone's as open and free. Even I
Yeah.
talk to some individuals who go to religious based institutions,
Mm-hmm.
and they said, hey, we're not supposed to have any sex. So there are no condoms anywhere. So
Mm-hmm.
they'd have to go, students have to go down to the FQHC, the Federally Qualified Health Clinic down
Mm-hmm.
the street,
Mm-hmm.
because the school said, no, we will not promote
Mm-hmm.
that. And it's like, whoa, knowing that's college age students are
Right.
partaking in this activity. So what do we need to do to get beyond some religious or
Mm-hmm.
structural barriers, and how do we need to, communicate that?
Yeah.
And I know there have been some success stories of some institutions saying, hey, it's for the well-being, and even providing, as you say, some data. You talk about panels. They say,
Mm-hmm.
hey, this is the data. We come, freshman students are,
Mm-hmm.
70% of these, young people are being diagnosed with sexually transmitted infections.
Mm-hmm. Mm-hmm.
This is why we need to have access to that, or a
Mm-hmm.
counselor there. And so just being very keen to what the data is stating,
Mm-hmm.
and the accessibility that people have. And so making sure that that's there. Again, if you don't have employment,
Mm-hmm.
do you have access to a doctor?
Yeah.
And so now you have to go, okay, I don't have employment, I don't have insurance. Then where do I go? Federally qualified health clinic,
Mm-hmm.
that may be several miles away.
Mm-hmm.
If you don't have a car, how do you get there
Yeah.
on a rainy day, on a stormy day? If you have 3 or 4 children, how do I take off? Where do I start? And 3 or 4 children that are under 5. I don't
Yeah.
have daycare. I don't do. So we're talking about quite a few barriers, right? That
Yeah.
we need to get beyond. So I'm talking to someone that has 3 or 4 kids, doesn't have a job, or a consistent job, that has access to health benefits, doesn't have a
Mm-hmm.
car, maybe living with uh, somebody, significant other, that may not,
Mm-hmm.
um, be best suited for them. How do you start to talk about condom negotiation? How do
Yeah.
you start about protecting yourself? How do you start to talk about some of these things when you're in a state of disarray?
Yeah. Yeah.
We have to understand that, you and I may be in a different situation,
Yeah.
but also understanding I know individuals who are in these situations, and sometimes it may be a trigger.
Mm-hmm.
So understanding that people are coming in with a whole set of stories,
Mm-hmm.
that we understand by just sitting there with you, and by you asking certain questions may trigger, may bring on a whole slew of emotions and feelings. And then some people don't even know that they're in
Yeah. Yeah.
situations that they can, oh, I can say no.
Right. Right.
I can ask someone to put on a condom.
Mm-hmm.
Or when I ask a significant other what's going on, and I'm consistently going down to the clinic and being tested positive for STI, and I ask my, partner, are you having sex with the other one? He slaps me,
Yeah.
or he says, are derogatory things to me, where I'm like, I'll never ask it again.
Mm-hmm.
So we have to really be keen. We have to find those ways, and that's why we are connecting with some of the traditional and non-traditional places. So we are getting to educate doctors and clinicians, very key, because
Mm-hmm.
we have to understand that those doctors who were trained 40 years ago, they might have still some stigma related
For sure.
practices that they engage in. So that's why I teach MD1 students, first year students, I'm introducing the curriculum. I'm introducing some of this information and knowledge, because
Mm-hmm.
these 22-year-olds are like, that's still an issue? HIV?
Right.
Providing trainings to OBGYNs, which
Mm-hmm.
women go and see, because we know research showing that many women, especially Black women who are high risk for HIV, are told that they are positive when they go in for pregnancy test.
Mm-hmm. Mm-hmm.
So in the nation, um, Atlanta's number 2, number of new cases. What's going on? The state of Georgia, currently, there are 60,000 individuals living with HIV.
Mm-hmm.
Atlanta is one of the highest cities. And we talk about, in the state of Georgia, Black females are living with HIV, 12 times as likely to be diagnosed with HIV than white women. Black men are at least 5 times as likely to be diagnosed with HIV than white men. This is an issue that can be prevented. And so we're finding ways and connecting with, those youth serving organizations, also with school districts that know we have, diagnoses that are starting earlier than 11 and 12 years old.
Oh, wow.
And so
Wow.
those are factors that we need to start educating. So we're connecting with pediatricians as well, because it is a grave issue. And just to highlight the what's occurring here in Georgia, as we talk about same gender loving men, some of the highest diagnoses of in terms of the population in Georgia. Second population is Black women, reproductive age women, and not just in urban areas, the surrounding area of Atlanta. We're talking about Georgia is 70% considered rural area. 50% of the new cases in the nation are diagnosed in the South. So we're strategizing how do we kind of really go in a deeper dive of what we're doing, whether we're in HBCUs, which we found is great connectivity with Gilead. They found it, hey, these are low-hanging fruits. Let's connect with the HBCUs, particularly those HBCUs that are training the next generation of future learners. So that's why they've come to Morehouse School of Medicine. We're connecting with Xavier University as well, their College of Pharmacy. We also know that initiatives are at Meharry Medical College in Nashville, initiatives going on to Drew and to Howard. We're in trusted spaces. We are a trusted voice. People come to us. We're often impacted, of course, most detrimentally, not just with our student population, but the population that we service. So at Morehouse School of Medicine, we are, of course, training our doctors who are going with the Morehouse healthcare clinics about what's going on and what we could do to provide more information. So you're talking with women and also going into with James Ginger Loving, extending it with trans populations as well. We have those who are going into trans informed care efforts, focusing on that population. So we have a great opportunity in this space in Georgia because we're here in Atlanta, knowing the diversity that's there. We have strong activists and advocacy here, but we also want to extend down into those rural areas where some of that 1980s communication, don't ask, don't tell, stigma, it's still stigmatized in a way, but we are happy to say that it is changing a little slower in some of those spaces.
And you mentioned there were children as young as 11 and 12 being diagnosed with HIV. And I recently learned that when we talk about sexual education, so sex ed in public schools, there isn't like a standard. It's not standardized. So some could be just talking about abstinence. And abstinence, in my opinion, is not necessarily, that's not one size fits all. That's number one. And number two, I feel like it's just, for me, I think it's a lazy way out because it's human nature, right? To have sex. So how are we approaching our younger people in a real way, in an effective way?
Policy has a lot to do with of the stuff. It's the underlying factor, the foundation, as we talk about in various, places and spaces, can adapt to what's occurring. We know programs that are occurring in so the West Coast, California, a little bit more progressive, certain cities that are there, they have started to talk about being individuals and having the sexual autonomy that you can do it. And we know that is there. Of course, in the South, where statistics kind of rule and data is indicating, hey, we need to really talk about this with the number of teenage pregnancies that are increasing, the increasing number of sexual transmitted infections. Let's talk about this. And so I know that some strategists have said, hey, let's go in some community-based organizations. Let's go into some of the youth-based organizations, even churches. In my day, they showed pictures that were trying to like scared straight. You would show pictures like, what is that? And some people said they never got that. And I'm like, wow. Show pictures that scared you, like, oh no, I'm never going to do anything. It's a bit different now. Now you have to have parental consent to talk. So I know we just had someone come from our efforts that we're working with, after school programs for Boys and Girls Club, some other youth organizations. And school embeddedness, it is very difficult. It can be very difficult. Like I said, I know some individuals that are working more positively in the West Coast and also Northeast, like New York, some spaces in DC. The South has yet to do that, especially with some of the mandates and requirements that are supposed to be addressed. Especially, traditionally it was through health ed, right? Health education. But to really talk about that and formalize that, I know that there have been some connectivity with parent groups and organizations, because oftentimes they're saying, okay, we can't talk about it in school. We need to talk about it somewhere.
Right.
Where do we put this information? And so placing some of that onus upon parents is key, to say, hey, this is time to talk with your children about what's occurring. It doesn't have to be so heavy, but you need to tune in to what your teens, what your young people are saying and doing, if you can. So we're trying to, kind of circumvent some of the barriers that have put in place there by policy and restrictive efforts, but making sure that we somehow connect with the populations that are at need.
So let's talk about the policy portion. So what are the political determinants or possibly political barriers to testing and all of those things, diagnosis, treatment?
Well, policies dictate what money is going to
Mm-hmm.
go toward educational efforts, right? And so if you have policymakers who are still thinking like it's 1980 diagnosis, which you might still have individuals who are in there saying, okay, I don't know what that is. I'm not advocating for millions of dollars to go toward an educational component or medicines in the health department. That's upon that individual. They're demonizing, they're doing bad things, demonizing that, therefore cutting off, eliminating funds that could help just someone thrive and live daily. So if you even talk about medications, how do we do that when you talk about PrEP? That's a preventable medication. But you have individuals that aren't readily open. We have to go another route, and so there are individuals, luckily, that are in the legislative making processes and involved in that protocol, that are advocates and activists. And so it's great to learn from the others who've tried to do it for years. And so we in Georgia have great advocates that were like, okay, well, they didn't really agree with it, but we're going to go with these 3 or 4. We work with those representatives or congresspersons statewide, and then we also continue to amplify the message and connect with our our respective representatives for the U.S. Congress. So we've had events that, we have an upcoming event to bring policymakers in to talk about how do you prescribe PrEP in a community-based setting. Using pharmacies, what do we do? There have been some great efforts in about 10 other states, and Louisiana has been one of them, and they're going to come and talk about what we need to do to strategize and present policy and legislation, because they had to walk that walk in these spaces. So we all connect with lessons learned.
I do want to talk about PrEP. For those who may not know, that is pre-exposure prophylaxis medications. So at one point, when during the advent of those medications, during the first discovery of those medications, they typically were reserved for those who had been like victims or who had been for sure exposed to the virus. Now we're seeing that you can just ask for PrEP. Now, is that something that is based, like the criteria to get it prescribed? Does it vary from state to state? Are you seeing that?
Yes, it does vary. Number one, you have so some people can get it through their doctors. Some people can get it nationally through pharmacies, which people are saying we need to have more accessible, because not everyone has insurance. Right. So some people can go to CVS and say, hey, pharmacist, can you prescribe me PrEP? That's a way of getting around that barrier. So there are about 10 other states that do this. But we here in Georgia, we're learning, what are the best ways of educating? Where do we need to go? So PrEP is very key, but also when you do get into that clinical visit, how do I, navigate? What are some points that doctors are asking? Okay, I think I know what to do, but how do I really address it? So there are toolkits that are being developed and tested out with clinicians. And there are some very brave clinicians that are saying, hey, when I have somebody that comes into my office and saying, hey, I've had 3 or 4 different men over the years, and I have 3 or 4 different kids, and they're coming in with 3 or 4 diagnoses of STIs, that's when doctors are saying, hey, however, we're also educating doctors that you need to ask the questions and create that relationship. We know you only have 8, 9 minutes
Right.
mandated that you can only spend, but making sure when you say that, saying, hey, okay, you saying you don't have sex, but in the event that you do, are you looking at protection? Are you looking at PrEP? Are you doing to bring that to normalizing, that type of conversation? And even if it's a heterosexual male or female, right? If it's the same gender loving male or female, and even as trans communication is being produced and prepared, what is to occur there. And we work with several providers that work with throughout the populations that are HIV possible, and we're excited that we're able to do that.
I really appreciate that you mentioned and that you highlight that we're all HIV possible. If you're engaging, yes, you are. It's possible, right? So a lot of the audience are parents. So parents to elementary age, middle school, high school age people. We know that it's super important for us to educate our children first, right? So what are some talking points that you would suggest maybe for our younger people? So like, let's say 10 plus. And then as we move forward, what are some talking points? What are some good questions to ask maybe?
And I have an 11-year-old boy, which I would say he was more talkative. Now he's in middle school. So, I have to kind of pull some things out because,
Right.
you not be amazed if you understand, they're on social media, they're in spaces and places where, parents are no longer there. But when we do have conversations where he's feeling free and he's feeling, okay, mommy, this and this and that, this happened. And this girl said this to me. And I'm like, oh, she did? Well, how did she feel? What did you feel talking with her? And he's saying, oh, mommy, oh, I felt this way. And then, to continue to engage. I think creating that trusting communication, making sure that communication is open. We know that our children, are not going to tell us everything. You didn't tell your parents everything. I didn't tell mine. So, well, what is that? And I often kind of refer, okay, what would I have like my mom or dad to ask about? And so I say, okay, well, how are you feeling about her? Are you guys talking about sex? Is that anything? No, mommy. And I said, okay, well, mommy, just asking, it's going to come a time where he's able to say, oh, yes, we're talking about this. But it's, and you can tell the difference that's coming up in the talk, and whether someone's talking about someone's anatomy or different things. So you have to just kind of tune in and just, not with a shocking and a raised voiced type of communication effort, but just to say, okay, so, how you feel about it? And it's hard to not feel shocking, and be shocking.
Right.
I've heard from my other friends that have older children to try and put those, oh my God, you did that, just saying, okay. Well, why'd you think that? What's going on? And to really have that open, non-judgmental, dialogue. But just tapping into your child, I think, is key. And I wouldn't say there's one or two kind of in the mold, but I would say, if you have a sexually active and more advanced, older child, to connect with them and say, hey, are you using protection? I've talked to my friends and they've said, oh gosh, I wish I would have asked my child, hey, how are you feeling about, having sex? But then also tapping into your pediatrician, I think, is also key, because pediatricians also have that training and that knowledge to say, okay, this is it. And even a trusting adult, they can't talk with you. They can talk to someone. The key is to talk and to discuss.
Yes. Yeah. Yep. For sure. And I think that even like outside of like parenthood, I think it's just important for us to talk about it. It is, like there shouldn't be a stigma, especially at this point where we know so much about the virus, right?
Yes.
Like, let's just talk freely and non-judgmental. You mentioned that earlier, like no judgment, just approach people with love, with openness. And how do we, either prevent it? And if it is contracted, how do we thrive with HIV? Thank you for this really robust conversation.
I'm excited that you were able to have me today to continue to talk about our efforts, what we do at Satcher Health Leadership Institute, as we want to be the leading transformative force, linking policy and health equity. And of course, in a space at Morehouse School of Medicine where we're able to train the future leaders in healthcare, in public health as well.
Yes. Thank you, Dr. Standifer. I really appreciate your time. Thank you for listening to this episode of Be Well Sis. If you'd like to get in touch with us, there's a link in the show notes. Be Well Sis is hosted by me, Dr. Cassandra Dunbar, and produced by Edit Audio. Don't forget to hit follow so you never miss an episode. Until next time, be well, sis.